Hi guys, welcome back. The topic that I'm going to teach you is now renal tubular acidosis. There are three varieties of it, that is RTA1, 2 and 4. And though we'll begin by describing regarding RTA1, if he says in the MCQ that overall what is the most common type of renal tubular acidosis which is encountered in clinical practice, then your answer would be given as type 4 renal tubular acidosis. Now, when it comes to RTA1, the site of damage would be in the distal convoluted tubule. And in the later part of the discussion, you will hear me say that even in RTA4, distal tubule would be involved. So the query in your mind straight up would be that if in RTA1 distal tubule is involved and in RTA4 also distal tubule is involved, then why the different nomenclature? So give me some time as we progress in the discussion. I'll be able to explain that to you, that though the site of lesion in both of them is the distal tubule, but there are different nomenclatures being used. Now, when it comes to RTA1, what's happening is that in the distal convoluted tubule, we have a couple of cells. One of them is called as alpha intercalcated cells. And the main function of this alpha intercalcated cells would be that they will help in potassium balance, or they will help in potassium excretion from the body. The importance of knowing this would be that suppose if there is going to be a damage to the alpha intercalcated cells, then this hydrogen ion excretion would not take place, and therefore you would have a buildup of hydrogen ions in the body, and that will explain the metabolic acidosis component. You see, one of the basic functions of the kidney is to maintain the acid-base balance in the body. So we also have what is called as beta intercalcated cells, and these chaps are responsible for bicarbonate excretion. So you can see that the kidney is able to maintain a fine balance between the base and the acid component, and thereby helps in keeping a stable pH of 7.35 to 7.45. Now, what I'm saying is that in RTA1, what fundamentally happens is that these alpha intercalcated cells would not be functioning properly, as a result of which the first manifestation that develops in these patients would be written in MCQs. I mean, obviously we are talking about metabolic acidosis in the patient, but how would he write it in a multiple choice question is what we need to learn. So he will say impaired hydrogen excretion, primarily because the alpha intercalcated cells are not working, and therefore metabolic acidosis will ensue. Now, there's a separate function of the kidney as well. Like I told you that one of the functions of the kidney is maintenance of the acid-base balance. The second important function of the kidney, over and above the acid-base balance maintenance, is that it is also responsible for maintenance of electroneutrality. By electroneutrality, I mean the positive charges and the negative charges will have a balance. I mean the positive and negative will cancel each other out. So what's happening here is that hydrogen ions, which are positive, are not getting excreted. If positive charges will not be excreted, then the kidney will respond here by also causing a impairment. This point number 2 that I'm saying is the response of the kidney, that it will respond by impairing chloride excretion. Now, if you look at it from the mathematical perspective, I can say positive charge was not getting excreted. So the kidney decided that, okay, I will not allow the negative charges also to be excreted. And now the positive and negative charges can balance each other. I mean, that's what I mean by the word electroneutrality. But the importance of knowing this fact is that because there is an impaired chloride excretion in the patient, that is why whenever you read about renal tubular acidosis topic, the textbook will always say this term, hyperchloremic metabolic acidosis. I'll explain this point once again. Metabolic acidosis is easy to understand. Hydrogen ions are not getting excreted from the body. But what I'm trying to now say is that to counterbalance, the words are to counterbalance the positive charges in the body, the negative charges, excretion will also be impaired. The kidney will, this is point number 2, is the response of the kidney to impairment of inability of the body to get rid of the positive charges. So the negative charges rise, and therefore you have is a hyperchloremic metabolic acidosis developing in the patient. The third point is again important because we are talking about distal convoluted tubule. And while I'm describing the kidney topic, I can say that nephron is the most evolved cell in the body. Yes, guys, it's not the neuron, it is nephron, which is the most evolved cell in the body, because every millimeter of the nephron has a different function. So we also have what is called as a hydrogen potassium exchanger, that is H, which is written by nomenclature as H plus K plus ATPase, and because this is present in the distal tubule and that's where the damage is, so even this would malfunction. Now the manifestations of this H plus potassium ATPase malfunction would be one, what I have already said, that hydrogen cannot be excreted. and therefore this can explain the metabolic acidosis component once again. But I broached this topic once again to say that if hydrogen will not be excreted, then potassium reabsorption will also not occur. You see, what I'm describing at the moment is that the person would be having a kali urea. Why I'm saying a kali urea is because this exchanger will function like this. It is supposed to get rid of hydrogen ions and simultaneously reabsorb potassium. If you look at the literature or the theory that I'm writing, I'm saying potassium cannot be excreted. That means it is getting lost in the urine, and therefore I can write it either as kali urea, or instead of saying kaliuria, the MCQ will say point number 3, which is to be noted down by you, is hypokalemia, which can explain the muscle cramps and the weakness and even possibility of tachyarrhythmia. As you see, hypokalemia can trigger torsades de pointus. So he can describe muscle cramps, weakness in a child or in an adult, depending upon whatever is the cause behind it. But hypokalemia is one of the components that is encountered in RTA1. And right now, I want to tell you an important hack from the MCQ perspective, that when I will be describing RTA4 to you, then I'll describe patient would be having hyperkalemia, but at the moment I've described hypokalemia. So I will give you logic for even why do you have a hyperkalemia in RTA4, but at the moment the logic that I've given you for why do you get a hypokalemia in these patients would be the hydrogen potassium exchanger is not working fine, you are having a kaliuria, and therefore hypokalemia manifestations would be occurring in the patient. Coming to point number 4 of this discussion, because this chap is having metabolic acidosis, these H plus ions can cause damage to the bone. Now, because of the damage to the bone, one manifestation that can develop is rickets or osteomalacia, especially from pediatric perspective, rickets from adult perspective. There can be a osteomalacia in the patient. But over and above this, what also happens is that because of the damage to the bone in these patients, the calcium concentration in the urine will increase. Now, because the calcium in the urine will tend to increase, therefore, you can understand I'm trying to point towards development of kidney stones in these patients. So, RTA1, that is distal renal tubular acidosis, is associated with development of calcium oxalate stones. I also want to tell you for point number 5, I mean, this would help you even in the kidney stones topic as well. Just remember this basic hack or statement that I'm making. Citrate, which is produced by the proximal tubule of the kidney, citrate, this is a basic rule that I want you to remember, that citrate per se acts as an inhibitor for calcium oxalate. My point is, my statement is that citrate, which is produced by proximal tubule, it is reabsorbed also in the distal tubule. This citrate concentration in the urine, the statement of mine is citrate concentration in the urine is an inhibitor of calcium oxalate or a calcium phosphate stone. Now, why am I describing that to you is that our studies have shown that in people with distal RTA, though citrate is being produced by the proximal tubule, reabsorption is occurring also. They have documented that in these patients, there is a decreased urinary citrate. Now, because of this decreased urinary citrate, the implication from the patient's perspective would be that citrate, I said, inhibits the formation of the stones. And therefore, in this patient, because the protection is not there, therefore, there is a high tendency for development of stones in these patients. See, I could not have described point number 5. I could have straight away said that hydrogen ions are damaging the bone. There is a hypercalciuria. So therefore, calcium stones can be developing in these patients. But then, technically speaking, what type of calcium-based stones would be developing? That is calcium oxalate and calcium phosphate, because the inbuilt system in the kidney, which protects against the formation of calcium oxalate and calcium phosphate stones, would not be working. The concentration of urinary citrate in this patient is found to be lesser, which is why nephrolithiasis develops. Two the must-know points for the topic of RTA1 would be one, hypokalemia, and then would be nephrolithiasis. And why that's important is because even in RTA4, distal tubule is involved, but in RTA4, you would not have nephrolithiasis, and you would also, instead of having a hypokalemia, would be having a hyperkalemia. Now, once you get these points right, the question then arises, why is damage occurring to the distal tubule of the patient? What are the important diseases which could be contributing to this? Then one of the important ones to be remembered would be a condition having Bence-Jones proteins. So that would be multiple myeloma. I mean, you always study about myeloma kidney. We always read about amyloid protein deposition, but then tubules can also be damaged. And if the distal tubule is hampered or damaged, then RTA1 manifestations can occur. Another very important from the exam perspective is the topic of scleroderma. I can just say that every time you will read about this connective tissue disorder, I mean, traditionally, whenever we read about scleroderma, our thought process is always that, I mean, our brain will be, thinking about Raynaud's phenomenon and leather-like skin found in these patients, or subsequently pulmonary artery hypertension, because sclero basically means fibrosis. So what I want you to remember is that yes, we do have anti-topoisomerase antibodies here. We have Raynaud's phenomenon, multiple other manifestations. But in patients who are having scleroderma, we would also be having damage to the distal tubule, and therefore RTA1 manifestations would be occurring. Another connective tissue disorder, which would be remembered by you here, is Sjogren syndrome, which is called as Sika syndrome, where we have anti-Ro antibodies present. Then toxins can also contribute to it. So we can get RTA1 even in glue sniffers. When I say the word glue sniffer, I'm talking about toluene inhalation. I mean, we lots of time get these vagabond kids who would be doing this glue sniffing. So that's again, I mean, glue sniffing can contribute to metabolic acidosis in a patient by causing damage to the tubule. Which part of the kidney would be damaged? Your answer would be the distal tubule. And then drugs also can contribute to it. One of the must-know facts that I'm writing from the exam perspective that you should be knowing is amphotericin B. I mean, every time there is a question on amphotericin B, you would have all read about hypokalemia present with amphotericin B. And today I can justify that why do you get a hypokalemia with amphotericin B is because it causes a distal renal tubular acidosis, and in distal RTA, because the H plus potassium ATPase is not going to function, so there would be an excessive loss of potassium in the urine, and therefore hypokalemia manifestations would be occurring. Now, when it comes to the treatment of this condition, we don't have any definitive drug of choice. I mean, if the tubule of the kidney, because I said the nephron is the most evolved cell in the body, if it's going to malfunction, then you would not be having any drug that can repair whatever damage is present. But what I can do max in these patients is I can try and neutralize the metabolic acidosis component by giving oral soda bicarbonate to these patients. Mark my words there. I did not say this is drug of choice. All I'm trying to say is I'm trying to reduce the disability in the patient by trying to neutralize the acidosis component, because it's going to damage the bones. It's going to cause a hypercalciuria, and then subsequently even nephrolithiasis could be developing in patients of distal tubular renal tubular acidosis. It's written as DRTA or would be written as RTA1. Next up is RTA type 2, which would be called as proximal renal tubular acidosis. And let me just symbolically represent the proximal converted tubule of the kidney. And one of the important functions of the PCT would be that it would help in bicarbonate reabsorption and thereby help in maintenance of the pH of the blood. Now, I'll use a bit of physiology term here like TM. TM basically means tubular maximum. I mean, what is the maximum amount of reabsorption of bicarbonate that can occur from the proximal part of the convoluted tubule? Then the transport maximum or the tubular maximum for bicarbonate should be remembered as a value. I mean, this is value for you and me at the moment. Then I'll talk about what's going to happen in the patient. The TM for a normal person hovers around 26 to 28 milliequivalents, which ensures that the upper limit of bicarbonate in the body of yours and mine would be something in the range of 26 to 28 milliequivalents per liter. I mean, this is the upper limit of the bicarbonate in our blood thanks to the efforts of the proximal tubule. What happens in proximal RTA1 is that there is damage to this wall. I'll tell you reasons for that also. But if they ask you from the pathophysiology perspective that what happens in proximal RTA or RTA type 2, then your answer would be that the tubular maximum or the transport maximum for bicarbonate is reduced. The moment I say this, that the transport maximum for this is reduced, what's going to happen in the patient is, like, let me just put up the value which we encounter in these patients. What's going to happen in these patients is that the reabsorption of bicarbonate would be hampered, and therefore the word that I'm writing, you don't read this word anywhere else in medical literature, bicarbonaturia. The moment I say the word bicarbonaturia, everything else will fall into place, because if you're losing bicarbonate from the body, you see, we have protons, we have bicarbonate. If you lose bicarbonate from the body, then the acidosis component will occur in these patients. And there's a separate terminology also that you will read for the topic of renal tubular acidosis type 2. And you would hear me saying this term even when I'm describing Wilson disease. So let's just take an example. We have a kid with Wilson disease. He's having neurological features. He's having damage to his liver. And in patients of Wilson, urinary copper is increased. So let's just assume, I mean, copper is going to flow down through the tubule, so it's going to cause damage here, and this damage will cause bicarbotinuria in the patient. Apart from the bicarbotinuria component, I can say that apart from this, I mean, we also have a couple of other transporters which would be helping in reabsorption of, for example, sugar or amino acids or phosphates. So if we are gonna have damage here, yeah, I'll just put a symbolic cross here to symbolize this, that due to various reasons, it could be like Wilson disease or even multiple myeloma. I mean, multiple myeloma can not only contribute to development of RTA1, it can cause RTA2 also. And the end result would be that apart from the bicarbotonuria component, your patient would be having all these terms written. I mean, I can just say the word urea written after all of them. I mean, glucose is not going to be absorbed, so glucoseuria. Similarly, amino acids would not be involved, amino aciduria. The words that I'm writing are very characteristic, and therefore I can say that it is very hard to miss proximal renal tubular acidosis per se, because you would have this terms written like phosphaturia, amino aciduria, renal glucosuria, and bicarboturia, which will explain the metabolic acidosis in these patients. Apart from this, what we have also shown in these patients is that there is an enhanced bicarbonate delivery to the distal tubule. You see, what's happening in these patients is that the damage is in the proximal tubule, so therefore bicarbonate going to the distal tubule would be relatively on the higher side. And now I can once again say the concept of electroneutrality. I'll write EN as a short for it. You see, I said one of the basic functions of the kidney is to maintain electroneutrality, and negative charges in the urine are increasing. So to counterbalance these negative charges, what the kidney will do is it will deliberately reduce the potassium reabsorption. You see, potassium can be reabsorbed via the distal tubule. The kidney will deliberately, in this particular case, counterbalance the negative charges. It will tend to increase the potassium secretion. I'll repeat the facts once again. Just imagine negative charges in the distal tubule. So what the distal tubule is doing is to counterbalance those negative charges. It will try to balance them by having positive charges, and positive charges are supposed to be reabsorbed. Potassium is supposed to be reabsorbed. This potassium would not be reabsorbed, and therefore in this patient you would again have is a caliuria. I've written increased potassium secretion, and this explains hypokalemia present in these patients. You see, hypokalemia is present both in RTA1 and RTA2, but is not present in RTA4. I have said that point earlier also. I'll give you justification for why do we get hyperkalemia in patients who are suffering from RTA4. But at the moment, the job for you guys is to understand that if you have negative charges delivery increase to the distal tubule, problem is in the proximal tubule. I agree to that. But if you have increased delivery of negative charges to the distal tubule, to counterbalance that, the positive charges are not going to be reabsorbed, and the kidney is trying to maintain electroneutrality, and therefore we get a caliuria and a hypokalemia component occurring in these patients. And now let us look at what are the diseases which could be responsible for causing this, and a couple of them that are important ones. Mark them out before you. Multiple myeloma is the common entry. Benzose proteins causing a myeloma kidney in the patient. Then it could be heavy metals. Heavy metal poisoning is what he could write. And then even scleroderma. I mean, as Sjogren syndrome, scleroderma. I mean, I can say that scleroderma per se, your primary answer would be given as renal tubular acidosis type 1. Make no mistake, fibrosis is occurring in the kidney. It's usually found in the distal tubule. Then when I was describing the topic, I did mention regarding Wilson disease, which has a high urinary copper, because in Wilson disease, the concentration of copper in the RBCs increases. And when those RBCs get busted, they get destroyed, then the urinary copper in the patient is also increased. Then a couple of drugs which could be contributing to this. The drug that I'm telling you at the moment is used in hepatitis B treatment, that is tenofovir. So one of the side effects can be damage to the proximal part of the kidney and development of RTA2 in the patient. Then an antiepileptic drug, that is topiramate. Drug part, like I was saying earlier, amphotericin B is related to development of hypokalemia and causes a distal RTA. Similarly, you need to remember the name of these drugs as well. And next, what I'm saying is important in a sense that traditionally, like if a person is taking expiry date antibiotics, you see, suppose the expiry date of a drug is 30th January 2023 or 2024, let's say 2023, 30th January 2023. And person consumes the drug in February 2023 or March 2023, post the expiry date, then what's going to happen? So it's only going to be the efficacy of the drug will be reduced. But when it comes to tetracycline, When it comes to tetracycline, there is a possibility that the person who has consumed expiry date tetracycline can end up with development of damage to his proximal part of the kidney, that is the proximal convoluted tubule, and RTA2 manifestations can occurring. So point number 5 is, I would say from the exam perspective, important for this topic. And now let us look at what are we gonna do in these patients for management perspective. So because there is a acidosis component, so even in these patients, I'll be giving is a soda bicarbonate, or instead of giving, sodium bicarbonate to the patient, I can be giving is potassium bicarbonate. I could have spoken about potassium bicarbonate even in my previous slide. I just chose to mention it here because hypokalemia is a common thing between both of them. So to take care of the hypokalemia component, one, I'll have to give potassium supplements to the patient, both in RTA1 as well as RTA2. But I will be going for potassium. The diet of a RTA4 patient who has a hyperkalemia will have a potassium which must be excluded. Like banana or coconut juice should not be, coconut water should not be taken by patients of RTA4, whereas in RTA1 I can allow them because there is a hypokalemia component present, and I can also give potassium bicarbonate to the patient. Please remember, what I'm telling you next is not the drug of choice. It is just that we are doing a theoretical discussion here. If any part of the kidney, especially the nephron, the PCT malfunctions, you just can't repair the defect which is occurring due to Sjogren syndrome or occurring due to heavy metal toxicity, but we give thiazides to these patients. Now look at the surprising thing that I'm telling you. Why are we giving thiazides? Because thiazides will cause diuresis in the patient and will cause dehydration to develop in these patients, and this dehydration will trigger metabolic alkalosis. The surprising thing is, even in pharma, they teach you one of the side effects of thiazide diuretics is that they cause a metabolic alkalosis. Why I'm causing this alkalosis is because person is having metabolic acidosis. So I'm just trying to, use one agent against another to neutralize, counterbalance the metabolic acidosis component. I am generating metabolic alkalosis in the patient. In case you're forgetting why thiazides would be contributing to this, what I say next is optional. That is, you can just listen to it. Because there is a dehydration, there will be activation of the RAS system. Every time you lose water from the body, diuresis, RAS would be activated. This RAS means that the aldosterone values would be increased. And look at what aldosterone does. Aldosterone will be causing a gain of salt and water. We all know that. But at the same time, it will also be promoting urinary loss of potassium as well as hydrogen. And if I exaggerate this, like let me just put plus signs here to say that thiazides will also contribute to an exaggeration of, it will try to get back salt and water. That's okay because of the dehydration component. There is an increased aldosterone in the body. But because of this exaggeration of the urinary loss of potassium and hydrogen, the urinary loss of potassium will be counterproductive because my person is already having hypokalemia. So hypokalemia can worsen in these patients if you use thiazides, but the advantage that you're getting is that you will trigger urinary loss of hydrogen. That is, you will cause metabolic alkalosis in the patient, and that will counterbalance metabolic acidosis. See, you cannot win the fight here. What I mean by you cannot win the fight here is that you are, as a doctor, about to lose not only the patient, but lose the fight as well, in a sense that there is no drug of choice for this condition. All I'm trying to do is counterbalance the metabolic acidosis component with metabolic alkalosis, and the disadvantage would be diuretics anyway cause a hypokalemia. So I agree to the fact that when I give thiazides to these patients, the hypokalemia component of the patient will worsen. The main highlight of this particular slide would be the term bicarbotinuria, or if he writes the word Fanconi syndrome, glucosuria, amino aciduria. Most people use these terminologies to crack that the question is based on proximal renal tubular acidosis, where the transport maximum or the TM for bicarbonate is reduced and you have a exaggerated urinary loss of bicarbonate. And because negative charges in the urine are high, therefore the kidney decides to counterbalance them by preventing the reabsorption or decreasing the reabsorption of potassium as well. And therefore the urinary loss of potassium in these patients also increases, which explains the hypokalemia component. Now, next up is RTA type 4, which is also written as hyporeninemic hypoaldosteronism. So let me explain what's the problem here. This is overall the most common type of renal tubular acidosis seen in clinical practice. As I've told you, the damage is still in the distal tubule. Now, what happens here is that there's another, I would say, channel present in the distal tubule, which is called as epithelial sodium channel, which is the channel which responds to aldosterone. So what happens in these patients initially is that we get a resistance. Aldosterone is very much there, but aldosterone is not able to act on the epithelial sodium channel, and therefore if aldosterone is there but is not able to act, it will not be able to cause a urinary loss of potassium and hydrogen. Let me at this moment draw this diagram once again before you, the one that we have drawn in endocrinology multiple times. The main function of epithelial sodium channel would be that it would be under the influence of aldosterone, causing a gain of salt and water, and simultaneously it will be causing a urinary loss of potassium and hydrogen. Now, if I say the word resistance in this case, I'll just put a cross symbolically for it. If this is not going to work, if it's not going to work, the first and the foremost manifestation that will occur in this patient would be there would be an impaired hydrogen excretion, or instead of saying impaired hydrogen excretion, he might write the word inability to acidify the urine. Now, if you are listening to me carefully, I have used these terms even with respect to renal tubular acidosis type 1, where I was saying alpha intercalcated cells are involved. But this time it is epithelial sodium channel resistance which is occurring, because of which hydrogen would not be excreted and therefore acidosis will occur in a person. But the second point, and I mean one of the main reasons why we're studying this topic, is that there would also be in this patient inability to excrete potassium, and as a result of which hyperkalemia manifestation will occur. Most of the time in the exam, they love to ask regarding what happens to potassium in RTA 1, 2 and 4. Your answer would be in 1 and 2, there would be hypokalemia, and in RTA 4, there will be hyperkalemia. And instead of trying to remember why for RTA 1 and RTA 2, which involves the concept of electron neutrality, I personally feel when I was at your age, I used to find it much easier to remember it, that the reason for hyperkalemia in these patients would be that the epithelial sodium channel is not able to function optimally. Now, see what happens in this patient subsequently. In the same patient, as the disease evolves over time, what we get is, you see, every time there's a defect of the receptor. Let's take example of type 2 diabetes. In type 2 diabetes, the receptor is resistant. So initially, the insulin values in the patient can increase. Increase why? Because after all, I mean, that's the basic rule of endocrinology. If in endocrinology any receptor is not working, then the primary hormone will increase because it will not be utilized. But in the later part of type 2 diabetes, we have is a beta cell exhaustion. The cells get frustrated and they say, "Aap kaam nahi ho sakta," and you get a insulinopenia. I repeat again, in type 2 diabetes, initial part we have is an increase of insulin. In later part of the illness, there is a beta cell exhaustion. The cells get tired, they get fed up, and there is a insulinopenia. Insulin tends to decrease. Similarly, I'm saying in RTA4, initially aldosterone values would be increased, but they will not be able to act because the receptor is not working. And subsequently, in the same patient, what we find is that aldosterone production tends to reduce. The cells producing aldosterone are tired, they're frustrated. So my point is, why did I say that this is a hypoaldosteronism, renal tubular acidosis, is because subsequently the aldosterone production in these patients would be substantially reduced. So either of the two words can be remembered by you. I mean, either you can just remember RTA4 is characterized by the receptor problem, or for that matter of fact, you can remember in the same patient in the later part of the illness, aldosterone will not work. Whichever you want to remember on your comfort level, but the end result will be the same. Whether I say the channel will not work, or whether I say hormone is not there, like let's just say if hormone is not there, then salt and water will not be gained, and potassium will not be excreted, hydrogen will not be excreted, and therefore hyperkalemia and a metabolic acidosis would be occurring in these patients. And then he would love to ask you, why would you be having development of renal tubular acidosis type 4? And your first answer this time would not be multiple myeloma. You're not going to talk about any connective tissue disorder. Like in RTA1, I was talking about scleroderma. In RTA2, I was emphasizing regarding S-Jorgen syndrome. This time I'm talking about diabetes mellitus, that is diabetic nephropathy. Then even in HIV-associated nephropathy, we read about damage here. Then can be chronic tubulo-interstitial diseases. Chronic tubular interstitial diseases are covered in the topic of ciliopathies. That's a separate chapter. I mean, ciliopathy, we have autosomal dominant, autosomal recessive polycystic kidney disease, autosomal dominant tubulo-interstitial kidney disease. So all of them are discussed separately in the ciliopathies chapter. But then important cause of diabetic nephropathy for RTA4 must be remembered. And now let's look at what can we do for management of these patients. In all the previous examples, I was saying I can give potassium bicarbonate to the patient. But in this particular patient, I need to go in for a dietary potassium restriction. I mean, half the MCQs that come on the topic of RTA mainly are gonna delve into the aspect of potassium. So this time you're not gonna say that I'm gonna give potassium bicarbonate to the patient, because bicarbonate component is fine. We can utilize acidosis, but if I give potassium, then you very well know cardiac conduction disturbances. I mean, bradycardia can occur and a cardiac arrest can occur in the person as well. Potassium interferes with the conduction system in the heart. Apart from this, I will be using hormone replacement in this case, because ultimately aldosterone values are less. So in these patients, we can be using fludrocortisone. This would be a drug which will behave like mineralocorticoid, and this exogenous administration has been shown to cause. I'm not saying it's drug of choice. All I'm saying is it has been found that supplementation with fludrocortisone tends to mitigate the suffering or the manifestations in this particular patient. Another drug that is used is furosemide. In RTA type 2, I was talking about usage of thiazide diuretics. This time I'm talking about furosemide, which is a loop diuretic and has been shown to cause a reduction. At least furosemide will help me in reducing at least the hypokalemia component of these patients. So what we do next is a quick revision of the three types of renal tubular acidosis that I've explained to you. That is RTA1, RTA2 and RTA4. The defect in RTA1 is distal tubule. RTA2 is the proximal tubule, and then RTA4 is again the distal converted tubule. This time in RTA4 versus RTA1, you need to remember the difference would be with respect to damage to the alpha intercalcated cells, and then ultimately the H plus potassium ATPase is not working. As a result of this, the manifestations that will occur in the person would be, he will say impaired hydrogen excretion, or he will just say inability to acidify the urine. In fact, that's the one of the important options that would be given. Inability to acidify the urine. And why that is important is that though the person is suffering from systemic acidosis, I mean, normally when a person has acidosis, the kidney should be able to lose protons. But in this case, because there's a defect present here, so the kidney will not be able to lose the protons. So inability to acidify the urine. I mean, that's the statement. In spite of the fact that the person is suffering from a systemic metabolic acidosis, is one of the hallmark features of this condition. Along with this, electrolyte imbalance encountered would be hypokalemia. The logic for that has been given to you. The acidosis will cause damage to the bones. So we usually have is a nephrocalcinosis in this person as well. In proximal converted tubule, the main highlight feature would be bicarbonaturemia. Though I have described Fanconi syndrome, which will make it easier for you, because all the terms of urea, I mean, every time there's a term, you just need to suffix urea after it, like phosphaturia, aminoaciduria, glucosuria. So it becomes relatively easier for people to remember that. And one of the important reasons for why RTA2 could be occurring, though I said multiple reasons, including multiple myeloma, at least you can remember Wilson disease, and then you can remember Wilson can be present and can contribute to RTA1 also. I mean, don't be under impression that copper deposition will occur only in distal tubule or will occur only in the proximal tubule. Wilson will be written both in RTA1 and RTA2. But just to get a hang of the disorder, because when the ultrafiltrate rich in copper will flow into the kidney, first where will it go? Proximal tubule. So I said Wilson can cause RTA2 in a person, or I gave example of expedited tetracycline, whereas for amphotericin B, I was describing for RTA1. When it comes to RTA4 in the patient, the main end result is aldosterone values are lesser. If aldosterone is not able to stimulate the epithelial sodium channel, again, you would be having the same thing written, inability to acidify the urine. And apart from this, he will also say that the person is having an electrolyte imbalance, but that's not going to be hypo, it's going to be hyperkalemia. And there's going to be no nephrocalcinosis that would be present in the patient. So do remember these aspects that I'm trying to tell you. I mean, Fanconi syndrome will make your life easier. Hypokalemia is a common manifestation. In fact, I'll just put a down arrow for potassium. Hypokalemia is present both in RTA1 and RTA2. I've given justification for the both of them, but hyperkalemia is a component seen with RTA4. So this would be a quick table for the three varieties of renal tubular acidosis that I would like you to remember. And in fact, this summary table, I mean, if you, my personal suggestion to you would be that on a stick-on pad, just try to, note down this summary table, not over 3-4 minutes, but in 1 minute, because in question, ultimately, you get limited time you have a limited time at your disposal. So you should be able to work out these aspects. The moment you read inability to acidify the urine, I mean, you are checking for what is the potassium value. Are kidney stones described in the question or not? Or is he saying decreased urinary citrate? Remember, I told you citrate, it helps in preventing calcium oxalate stones. So metabolic acidosis and bone disease can be occurring in these patients, especially in pediatric presentation, you could be having rickets, and in adult presentation, even osteomalacia could be written. Another reason why this term is being discussed, renal tubular acidosis, at the moment before you is with respect to the concept of anion gap. Now, per se, when it comes to renal tubular acidosis, RTA, you need to remember the person would be having a normal anion gap. Why a normal? I'm using the term NAGMA, that is normal anion gap metabolic acidosis. Why normal anion gap? Because the positive and the negative charges would be lost equally. You see, anion gap is a gap of the difference between positive and negative charges. If both of them get reduced by equal amount, then mathematically the value of anion gap would remain the same. So in all the, in all the three varieties of renal tubular acidosis, normal anion gap metabolic acidosis would be found. Then he's also going to talk about urinary anion gap. Now I'll tell you the formulas for urinary anion gap also. But at the moment, you just need to remember the information. Normal anion gap metabolic acidosis in the blood. But in the urine, you need to remember renal tubular acidosis, urinary anion gap will be positive. I can go into the mathematics of that as well when I get into the formulas, but at the moment the data is being presented to you. I mean, what he expects in a question is not only that you should be able to determine that whether it is RTA 1 or 2 or 4, or whether there is a hyperkalemia associated with the a patient of renal tubular acidosis type 4 variety has presentation of hyperkalemic acidosis. I mean, earlier I was saying hyperchloremic, but I'm saying in this chart, there would be a hyperchloremic acidosis, that's okay. But simultaneously, there would be a increased potassium because of the inability of aldosterone either to act, or aldosterone values are lesser in the patient. And then we'll compare this with a patient of diarrhea. You see, let us take a case of cholera. In cholera, positive charges in the stool would be lost, negative charges would also be lost. So diarrhea is also an example of a normal anion gap metabolic acidosis. But the point that I want you to remember is that urinary anion gap is negative with respect to diarrhea. Now look at the spelling of the word negative that I've written before you. Normally negative should be NEGATIVE. Just for the sake of remembering, I am saying the alphabets that I'm using is GUT. I mean, when you have a gut problem in the patient, then negative is the word which is to be remembered. So normal anion gap metabolic acidosis is common between renal tubular acidosis as well as diarrhea. The difference is with respect to urinary anion gap in a patient. Over and above this, I would also like to add that in a person who's suffering from diarrhea, there can also be muscle cramps, hypokalemia will occur. So you are having a hypokalemic acidosis. Where are you having a hypokalemic acidosis? RTA1, RTA2, and even in a case of diarrhea. But where do you have is a hyperkalemic acidosis? Then hyperkalemic acidosis would be renal tubular acidosis type 4. Once we get this table right, we'll just write down the formulas for anion gap as well. The formula for anion gap, please remember, would be difference of positive and negative charges. Positive would be sodium and potassium, but do not include potassium in the formula per se. It will be given in the question, but your job would be to negate it, because by the convention, the formula for anion gap is sodium minus chloride plus bicarbonate. And I'll just put in a couple of values there, normal values like 140, average of 135 to 145 for sodium. Chloride values are between 96 to 106. So let me just put up a value of 100. And bicarbonate values are like, approximately, I would say, I'll just put chloride to be on the higher side so that it's easier for me to do mathematical calculation. 106. Bicarbonate, I'm taking an average of 24 millicoulombs. So if you just get into the mathematics here, 140 minus 130. So the value will turn out to be 10. The normal value of anion gap would oscillate between 6 to 12 millicoulombs. Though in some books it might be written 8 to 16 milliequivalents, but most textbooks like Harrison mentioned between 6 to 12 milliequivalents. So anion gap, they can make you calculate this as well. I mean, they'll give you sodium, potassium chloride and bicarbonate values. Just negate the potassium values, whatever is given, and you can calculate the anion gap. I have done a normal calculation for us, and I've taken a chloride value to be on the higher side for ease of calculation. Now, when you compare this with the urinary anion gap, be very attentive when I write the formula before you. In urinary anion gap, we are taking into consideration sodium in the urine. This that I'm writing is sodium not in the blood. It is sodium in the urine and potassium in the urine. Earlier, I was saying neglect potassium. That was for the blood. But in urinary anion gap, you have to take into consideration potassium in the urine. And in the negative charges, you will not incorporate bicarbonate, but you will take a chloride value. If it says what is the normal urinary anion gap, then your answer would be yes, guys. What's normal urinary anion gap? Remember, I told you urine is electroneutral. Positive charges, negative charges balance each other. So normal urinary anion gap is 0. That explains the concept of electroneutrality, which I was emphasizing during my discussion of RTA1 specifically, that the kidney is trying to maintain electroneutrality. So positive and negative charges would be equal. Once you get the formulas right, then what I've explained to you is urinary anion gap. You can divide this into two. Urinary anion gap is 0. When would you have a negative value? Then I told you a hack to remember it. I mean, instead of saying negative, just write it as gut problem, and the gut problem would be diarrhea. And when do you have a positive urinary anion gap? That would be renal tubular acidosis. Now for this positive negative, I can go into this formula also, and I can, make life difficult for you, but then it would not serve any purpose. I mean, I can give you logics behind these also, that okay, why this? I mean, it will be purely mathematics. It would not help you solve the questions per se. So I'm just telling you a hack that every time you read diarrhea, your thought process is, yes, there is a hypokalemic acidosis. In RTA4, there would be hyperkalemic acidosis in a patient, but then the urinary anion gaps are also to be remembered for this particular topic. Next, I'll also make you revise regarding causes of high anion gap metabolic acidosis, that is HAGMA and NAGMA. So let's just practice that. HAGMA is high anion gap metabolic acidosis. NAGMA is normal anion gap metabolic acidosis. For HAGMA, the mnemonic is very easy to remember, that is CULT. Alphabet K would stand for ketoacidosis. He can give a scenario of diabetic ketoacidosis, or he might talk about a politician on a hunger strike, or a farmer who's not eaten for 10 days. He went into starvation and then resulted in a ketoacidosis. Burning of fats, that's subcutaneous fat oxidation, would generate ketones. So starvation / alcoholic or diabetic would be the scenarios for ketoacidosis. Alphabet U would stand for uremia. So he could describe acute kidney injury with respect to viper bite, rhabdomyolysis, crush injury in an individual, or he can write acute tubular necrosis, or he can write chronic kidney disease in a patient. I mean, every time we have a parenchymal disease of the kidney, that is going to contribute to a high anion gap metabolic acidosis. Alphabet L would stand for lactic acidosis, which would be like of type A, type B. Like type A is related to circulatory failure. Like if a person goes into shock, cardiogenic shock, distributive shock, it's type A lactic acidosis. But if he says diabetes mellitus leads to, answer is type B lactic acidosis. I broached that or talked about it even in the diabetes topic. And then alphabet T would stand for toxins. In toxins, he could be talking about methyl alcohol poisoning, or it could be ethylene glycol poisoning. So my point is that this mnemonic would make it easier for you to remember regarding causes of high anion gap I mean, if the question begins with an alcoholic or a starvation scenario, even before you do the mathematics, he might ask you to calculate the anion gap, but if he's talking about a farmer who has maybe gone on a hunger strike and he felt so sick, and then he's going to describe that this farmer or this politician was hospitalized, you know that if he's giving you the history of starvation, at the back of your mind, the mathematical calculation would be that anion gap values would turn out to be in excess of 12. When it comes to NAGMA in a patient, the mnemonic to be used is Dr. Fuse. Though, there are multiple other conditions also which cause a normal anion gap, but at least the minimum are these that I would like you to remember. That is diarrhea. The R would stand for renal tubular acidosis. Now that is the key. The key is that parenchymal disorders of the kidney, like acute kidney injury, chronic kidney injury, chronic kidney disease, they are all are going to cause a HAGMA. But the tubular disorders of the kidney are going to cause an AGMA. Why? Because the positive and negative charges would be lost equally, and therefore, if positive and negative both are lost, the mathematical value will remain the same. Then alphabet F would stand for fistula. Again, the logic is positive and negative charges would be lost simultaneously. And the use word, USC, use word would be used to remember regarding what I'm writing at the moment before you. That is ureterosigmoidostomy. That's a urinary diversion procedure that I'm talking about. But I just made you revise regarding the causes of HAGMA versus NAGMA. And apart and over and above this, you can also ask you conditions where anion gap would be lesser. Yes, guys, I'm giving you a second to think about condition that are described in hematology where you would be having is a decrease in line gap. The condition would be having crab criteria. Why do you get a reduced line gap in multiple myeloma? You can go to the multiple myeloma video where I've gone into mathematics and explained that. But I've just used this opportunity to make you revise regarding causes of high in gap versus normal in gap versus a reduced in gap. I've also tried to broach and make you practice regarding the urinary in gap. And anyway, the crux of this topic, the most important point in this topic is this table that I made before you for renal tubular acidosis, the varieties behind it. And then, I can also use this opportunity to mention a couple of disorders. You see scleroderma. Most MCQs will talk about anti-topoisomerase antibody and leather-like skin and Raynaud's phenomenon, but you need to remember RT1. Traditionally, when we read scleroderma, our brain is in all connective tissue disorder. We are talking about antibodies. We are not thinking about metabolic acidosis in a patient, and that is the point that he would like to broach here. And similarly, when you are talking about Wilson disease, then ultrafiltrate would flow in and will first cause damage to the proximal tubule, and then diabetic nephropathy is where you read about renal tubular acidosis type 4 as well. So there are a couple of etiologies, though I mentioned a list bigger than that. And then what are the manifestations? What would be the electrolyte imbalance differences seen in this condition is the main reason why this could be asked in the exams. So thank you so much for hearing, guys, and keep the pressure on, and you will definitely do great in your careers.